So thank you so much for the opportunity to speak about this topic. So atrial fibrillation is a huge topic, and it's very relevant, and it's something that is seen across specialties. So I'm going to focus on atrial fibrillation in the COVID era. I have no disclosures. So today, the plan is to cover the principles underlying the management of atrial fibrillation. And these are very simple, 3 things. And this is the take-home message, really. If you have a patient with atrial fibrillation, you have to consider, number 1, stroke prevention. Secondly, you have to think about whether you go for a rate versus a rhythm strategy, both in the acute setting and in the long term. And thirdly, you have to look at the concomitant conditions of the patient. Next, I will talk about some of the specific considerations that we need to think about during the COVID pandemic. And then I will end with some case examples if we have time. So atrial fibrillation is characterized by disorganized activity in the atria, and it is characterized and diagnosed based on an ECG demonstrating absent or abnormal P waves and an irregular R interval. Atrial fibrillation is the commonest sustained arrhythmia, and a sustained arrhythmia is defined as more than 30 seconds. In fact, it's commonly triggered by other things such as infection, and sometimes we call this secondary atrial fibrillation. It causes problems. It can cause heart failure, and it can cause that in 2 ways. It can cause a reduction in LV systolic function, or you can exacerbate heart failure with preserved ejection fraction. In patients who have pre-existing heart failure or an underlying cardiomyopathy, it can also exacerbate and precipitate heart failure. And it is important to recognize that atrial fibrillation can cause a reversible type of cardiomyopathy, and we call this tachycardiomyopathy. So, as I mentioned, the 3 simple ways that we assess all of our patients with AF, we have to think about, number 1, anticoagulation and assess their stroke risk. Number 2, a rate versus rhythm strategy. And number 3, to treat and optimize concomitant conditions. Atrial fibrillation can cause strokes, and strokes in atrial fibrillation are significantly more severe and more disabling than in the patients who don't have AF and have strokes. We have a host of medications, anticoagulation, that can reduce the risk of stroke in selected patients. Traditionally, we had warfarin, but now we have the direct oral anticoagulants, of which there are 4 types available. Atrial fibrillation is bad, and it can affect patients in 3 main ways. And this is what I tell patients. In some patients, it can increase the risk of a stroke due to left atrial thrombus. Secondly, it can cause heart failure. And thirdly, it can affect patients by giving them symptoms of AF. Atrial fibrillation has a number of associated conditions that can exacerbate atrial fibrillation, make it more difficult to manage. And by treating some of these underlying concomitant conditions, you can actually improve outcomes in patients with atrial fibrillation. And here are some examples. So sleep apnea, obesity, alcohol, heart failure, and hypertension. All have been shown if you treat these underlying conditions, you can improve outcomes in patients with atrial fibrillation. So let's start off with anticoagulation and stroke risk. So we have to assess the stroke risk of a patient, and we have tools available. The CHADS-VASc score is the one that we tend to use. And the principle is that if they have a higher risk, then you should initiate anticoagulation. Okay, and that's slightly different if you're male or female. So if you're male, a score of 1 or more, you should consider anticoagulation. If you're female, you need a score of 2 or more, because female gender is one of the risk factors. Secondly, before you prescribe the anticoagulation, you must think about the bleeding risk. And we can use a tool called the HASBLED score, and that gives us examples of some risk factors that increase the risk of bleeding. The principle behind this is that if you have 3 or more risk factors, then your bleeding risk is significantly elevated. Traditionally, many people use this score to deny patients anticoagulation, but actually how we are supposed to use it is that we can identify reversible factors and address those, because if we address them, then that will lower the risk of bleeding for the patient. It also means that these patients need to be monitored more closely, and we may need to consider switching patients from warfarin to a direct oral anticoagulant, particularly if their INRs are very labile, they're high or very low. In the COVID era, INR monitoring may be difficult because patients may not have access to their anticoagulation services. So it may be considered to switch patients from warfarin to a direct oral anticoagulant. If a patient has atrial fibrillation and is found to have COVID, and in that situation, we have to think about the anticoagulation. And during the acute illness, we should switch the direct oral anticoagulant to heparin subcutaneous. And this has been covered in previous webinars. Here is an example of the CHADS-VASc score, and you can see there are different risk factors. And I'm not going to go through every single one of them, but this is available in the guidelines, in the European Society of Cardiology guidelines. And also, this is the HASBLED score. And as I said, you can identify a patient who has a higher risk of bleeding, and you may be able to address them. So if they take drugs, for example, like non-steroidal anti-inflammatories, you can stop that, and that reduces the risk of bleeding. If their blood pressure is more than 160 over 110, for example, then you can address that by correcting their blood pressure, and you've lowered the risk. Next, we will move on to rate versus rhythm strategy. And this often causes a lot of confusion and a lot of stress amongst junior and senior colleagues. So I will start by inviting you to conduct a poll. And this is the case of a patient who is a 93-year-old female who has a background of hypertension, and she is admitted with fever, cough, and decompensated heart failure. She has been newly diagnosed to have AF with a rapid ventricular rate of 140 beats per minute, and her blood pressure is 150 over 90. Her COVID swab is positive, and she has been treated with diuretics, and she has been started on apixaban after her diuretics have been after she has recovered. Her echocardiogram showed preserved LV systolic function with a dilated left atrium and mild concentric left ventricular hypertrophy. So the question is, how would you manage this patient from a rate versus rhythm control strategy? And here are the options. Number 1, maximally tolerated beta blockers plus or minus digoxin, aiming for a heart rate of less than 110, a permanent pacemaker and AV node ablation, TOE guided cardioversion, electric DC cardioversion as an inpatient. Would you refer her for an outpatient DC cardioversion? Would you start antiarrhythmic drugs, for example, amiodarone? Or would you refer this patient for a catheter ablation, pulmonary vein isolation ablation? Dr. Abdulazim, if you can start the poll, that would be great. Okay, what's the answers to the poll? So we have majority of patients would, there's a split, okay? So half and half, okay? Half have gone for rate control with beta blockers and digoxin, aiming for a heart rate of less than 110. And the other half have opted for antiarrhythmic drugs, such as amiodarone. Okay, that's very interesting. Let's move on. Now, I just want to use this opportunity to describe this slide, and this is a very important slide. This tells us the natural history of atrial fibrillation, and it's available from the ESC guidelines, not the most current, the ones prior, 2010. As you can see on the left-hand side, you have patients who have silent atrial fibrillation. So they have these short episodes of atrial fibrillation. If you look at the blues at the bottom, you can see they have short episodes of atrial fibrillation that are very short-lived, and they're infrequent. And in fact, the patient is asymptomatic. At some point in the patient's life, they will have a documentation of atrial fibrillation, called this first documented AF. And then you can see at the bottom that the paroxysms of atrial fibrillation, okay, become more frequent and they become longer, to the point where patients may be hospitalized and require specific treatment. So the treatments are at the top. So you have upstream therapy of concomitant conditions. You consider anticoagulation once you've first documented. Patients may require rate control. They may require antiarrhythmic drugs. They may require cardioversion, an ablation. And what happens is that these patients who have paroxysmal atrial fibrillation, defined as AF lasting more than 30 seconds up to 7 days, it can become more persistent, where the patient remains in atrial fibrillation and requires intervention to terminate atrial fibrillation. And that may be with a cardioversion, you can see. Then the patient may have a period of time in sinus rhythm, and then they have a recurrence of the persistent atrial fibrillation. And as time goes on, they may develop long-standing persistent atrial fibrillation, which is defined as more than 1 year duration of atrial fibrillation. And at some point, the clinician and the patient may decide that actually we're going to accept atrial fibrillation, and that patient has permanent atrial fibrillation. The difference between long-standing, persistent, and permanent is that the patient and the clinician has decided not to pursue a rhythm strategy and to accept atrial fibrillation. That's permanent. So you start off with, this is the natural history of atrial fibrillation. Very important to understand. The second important thing to understand about atrial fibrillation is regarding this concept of the trigger versus the substrate. So in the green on the left, we know that patients with atrial fibrillation, the atrial fibrillation may be triggered by pulmonary vein activity. And you have sleeves of tissue, of atrial tissue within the pulmonary veins that shouldn't be there, that fire off, and that triggers the atrial fibrillation. And that can trigger an episode of paroxysmal atrial fibrillation. It can also maintain atrial fibrillation and make it more persistent. As time develops, so in this situation, the patient may begin with having a relatively normal left atrium, and they have paroxysmal atrial fibrillation. As time develops, the problem is no longer the trigger of the pulmonary vein, but it's actually the substrate is the problem, which is the left atrium itself. And we may call this an atriopathy, where the left atrium becomes diseased. And in that situation, attempts to control the rhythm may be very unsuccessful, and the patient is often left in a position of being in permanent atrial fibrillation. And certainly they're very challenging. There is in the middle, there is some overlap between the trigger and the substrate. So this question of rate versus rhythm control, which should you go for? This was this question was answered in a randomized controlled trial published in the New England Journal of Medicine in 2002, nearly 20 years ago. And I'm just going to briefly describe this study. Over 4,000 patients were randomized. This is a randomized controlled trial comparing rate versus rhythm strategy in patients with atrial fibrillation. The mean age is 70. Half of the patients had hypertension, so they were comorbidities, and almost a quarter of patients had heart failure. So what happened? On the bottom right, you can see in this Kaplan-Meier graph that actually at the follow-up of 5 years, there was no difference in mortality between a rate versus rhythm strategy. This was very surprising that a rate versus rhythm control strategy there was no difference. Now, when you look at the study in a bit more detail, you will see that the rhythm strategy involved combination of drugs and a cardioversion, and very few patients had catheter ablation. So really, this is a study comparing rate-limiting drugs versus antiarrhythmic drugs. The other problem with this study, or the difficulty, is that there was a very high crossover rate. This means that patients who were initially randomized to receive a rate control strategy ended up having antiarrhythmic drugs, and vice versa. Patients who were on the antiarrhythmic drug arm, some of those patients didn't receive them or didn't tolerate them and had to be switched over to rate control. Makes it very difficult to interpret. But the bottom line from this study is that there is no difference in mortality between a rate versus rhythm control strategy, and we're talking about drugs. But there was a subsequent study that reanalyzed the data and looked at what about patients at the end of the study who were in sinus rhythm versus patients at the end of the study who were in atrial fibrillation. And unsurprisingly, patients who were in sinus rhythm did have a better survival. So this study tells us that sinus rhythm is better than atrial fibrillation, but antiarrhythmic drugs are harmful, and that may cancel out the benefits. So the next question is, what about catheter ablation and pulmonary vein isolation, which involves creating a circle of scar around the pulmonary veins, either with the traditional approach on the bottom right-hand side, which was radio frequency, where you do point-to-point lesions around the pulmonary veins in a circle, versus cryoballoon ablation, which is a relatively newer technology, which involves placing a balloon catheter that's inflated just at the ostium of the pulmonary vein, and that delivers a treatment of 3 or 4 minutes to freeze the tissue, and that's in each of the 4 veins. The question is, does this approach fare any better? And this was tested in a large randomized controlled trial called the CABANA study, and this was looking at comparing catheter ablation versus antiarrhythmic drugs on mortality, stroke, bleeding, and cardiac arrest among patients with atrial fibrillation. So what did this show? This was a long-awaited trial, and there were over 2,000 patients randomized, largest study of catheter ablation. Patients were of a median age of 68, and 40% of them had paroxysmal atrial fibrillation, 80% had hypertension. And this was a randomized controlled trial comparing catheter ablation versus medical therapy. So what did it show? So on the bottom right-hand side, we can see a Kaplan-Meier curve looking at the primary outcome. And after a mean follow-up of 60 months, unfortunately, there was no difference in outcomes. Okay, now this again was very disappointing for electrophysiologists. there's no difference between catheter ablation versus drug therapy. Now, the study authors went on to do another type of analysis, okay? So there are two types of analysis. One is an intention to treat, which means we're going to analyze the patient based on how they were randomized. And in that situation, there was no difference. But you can do a second type of analysis, which is a per protocol analysis, which basically means, well, what about the patients who received drug therapy compared to those who actually received catheter ablation? And there was a difference. So catheter ablation was better in those who actually received it compared to those that didn't. But this is not the purpose of randomized controlled trials. The purpose of randomized controlled trials is to help you decide what you try to do for a patient. There were a number of problems with this study. Similar to the AFFIRM study, there was a high crossover rate, varying between 10 to 30% of patients who did not get what they were meant to get. And that's partly because the drug therapy was ineffective or it was intolerable, and also because patients may not want to have the catheter ablation, and sometimes patients or families change their mind. Also, there was a relatively high dropout rate of around 10%. So, any benefits to take home from the CABANA study? Well, yes. In a subsequent analysis, they published, they looked at what about quality of life? Did catheter ablation, being randomized to catheter ablation, have any effect on the quality of life rather than survival? And in fact, we can see here that the catheter ablation had better quality of life. And these are two of the quality scores that we use, AFFIRM and the MAFC score, which is a collection of questions that you ask patients regarding their symptoms and how much the symptoms impact on their quality of life. And it's very consistent that catheter ablation improves quality of life. So the take-home message from CABANA was that there was no difference in mortality and overall rate of the outcome between catheter ablation versus non-invasive approach, but there was definitely an improved quality of life with ablation. Is that the end of catheter ablation? Well, no, because there was a subsequent study that looked at patients who had atrial fibrillation with heart failure. As I mentioned, atrial fibrillation can exacerbate and can cause heart failure, and particularly heart failure hospitalizations. So the question here is, can a catheter ablation help in this group of patients? So this was a randomized controlled trial published in 2018 of around 360 patients. The median age was 64. A third of patients had paroxysmal atrial fibrillation. And you can see the patients were symptomatic. 90% were in New York Heart Association class 2 or 3. And this compared catheter ablation versus medical therapy. And medical therapy in this study included either rate or rhythm control. What did it show? So you can see here, this is the Kaplan-Meier curve with the primary outcome of death or hospitalization for worsening heart failure. And you can clearly see that after a 60-month follow-up, that the ablation group had much better outcomes, significantly better outcomes than medical therapy. And in fact, when you look at the different endpoints within the primary endpoint, the subcategories, you'll actually see that it improved death from all cause, and also it reduced the hospitalizations for worsening heart failure. So, conclusion of the CASTLE study showed that in patients who have heart failure with reduced ejection fraction, most of the patients had reduced ejection fraction. There was a mortality benefit with catheter ablation, and there was a significant reduction in heart failure hospitalization. So, question is, with catheter ablation, what can be achieved in atrial fibrillation? I think we look at things in two ways, survival and quality of life. Catheter ablation has not been shown to have any effect on stroke risk so far, but it has, all the studies are showing that catheter ablation reduces atrial fibrillation burden. This is a new concept. In the past, we would look at if a patient had a recurrence of atrial fibrillation, that would be classified as a unsuccessful ablation. But if a patient was in persistent atrial fibrillation before, and afterwards they just had one episode lasting 5 minutes, then that would be a significant reduction in burden of atrial fibrillation. It doesn't eliminate it necessarily, but it reduces the burden. And this may be one of the reasons, one of the mechanisms for the improvement in outcomes seen in the CASTLE-AF study. So we've seen that by reducing AF burden with catheter ablation, you can improve mortality and reduce heart failure hospitalizations in patients with heart failure and reduced ejection fraction. We can see that in some patients, actually, the natural history of atrial fibrillation can be altered and even reversed, with some patients can reverse from persistent to paroxysmal atrial fibrillation following catheter ablation. In some patients, we see that the ablation can increase the efficacy of medications that previously wouldn't work. We can see that after an ablation, sometimes these medications, the same ones, now can work and control their symptoms. And this is very important, is that catheter ablation has been shown to improve symptoms and improve quality of life in patients with atrial fibrillation. So I'm going to talk about the DC cardioversion next. Because DC cardioversion is something which is very commonly used, and sometimes it's not very sort of well understood of how to make the most out of cardioversion. So the first important point about a DC cardioversion is that it is very effective at restoring sinus rhythm. Or immediately, it can restore sinus rhythm with one shock. But it does not maintain sinus rhythm. So that means that a patient can be successfully cardioverted, but then they have a recurrence of atrial fibrillation. So something else in addition to the cardioversion often needs to be done to maintain sinus rhythm. And that's where you can think about antiarrhythmic drugs or catheter ablation. We find DC cardioversions very helpful to help us to plan for, whether we go for a rate versus rhythm strategy in patients. And the reason for this is that if a patient, you send for a cardioversion and it successfully restores sinus rhythm, we can assess the symptoms of patients. Some patients say, I don't have any symptoms. They're in atrial fibrillation, they're rate controlled, I have no symptoms, doctor. But when you do a cardioversion and they're in sinus rhythm for a period of time, many patients will say, well, actually, I thought I didn't have any symptoms, but I felt much better after the cardioversion. So it helps us to understand what the impact of atrial fibrillation is having on patients in terms of their symptoms and their quality of life. And it helps clarify that with patients as well. Some patients will say, I noticed no difference before and after the cardioversion. So they can't tell a difference between sinus rhythm and atrial fibrillation. So in that situation, we may not need to pursue an aggressive rhythm control strategy. The third point I want to make is a distinction between the terms of a successful versus a failed cardioversion, because we often get referred patients who've had failed cardioversions. And actually, when you go back and have a look at what happened in the cardioversion, they'll be referred for a cardioversion, it restores sinus rhythm, they're discharged with an ECG showing sinus rhythm, But then when they come back for their follow-up check in 2 weeks, 4 weeks, 6 weeks, they have atrial fibrillation. Many people would label that as having a failed cardioversion, but that is not the case. That is an example of a successful cardioversion, but the patient has had a recurrence of atrial fibrillation. So in fact, if a patient has had a cardioversion and they managed to restore sinus rhythm for a single beat, that would be classified as successful. So if they had a single beat of sinus rhythm and they went straight back into atrial fibrillation, that would be called a successful cardioversion with recurrence of atrial fibrillation, a very early recurrence. A failed cardioversion is one where the patient receives a shock that does not terminate atrial fibrillation. And then you may escalate the number of joules, and you may change the pad position. You may apply pressure to the pads. And in that situation, you repeat the shock, and still it does not terminate atrial fibrillation. That would be classified as a failed cardioversion. And in that situation, that is telling us that this patient will have very difficult to control atrial fibrillation, and it'll be very difficult to maintain sinus rhythm. And perhaps we're dealing with a problem of a substrate rather than just a trigger of a pulmonary vein. And a catheter ablation of pulmonary vein isolation may not benefit that patient because they have a very advanced disease. So what do you do if it's a failed cardioversion? Well, actually, you need to look at antiarrhythmic drugs, because some patients, if you put them on antiarrhythmic drugs, it will increase the chances of a successful cardioversion. So in that situation, if I had a patient who had a failed cardioversion, I would then send them home, start them on amiodarone, discuss it with the patient, of course, counsel the patient about the side effects and the risks, and consider starting them on amiodarone and bringing them back for an amiodarone facilitated cardioversion. That's for us, that would be a second chance. If, despite being on amiodarone, which is the most potent and effective antiarrhythmic drug we have available, although it has toxic side effects, if the patient is unable to cardiovert that patient, then that tells us that a rhythm control strategy will not be successful in this patient. So just to briefly summarize, the two questions really that cardioversion gives us are, number one, can sinus rhythm be restored with or without amiodarone? And number two, does the patient notice any symptomatic benefit from sinus rhythm? So what should we do? If the patient has hemodynamic compromise, then we should give them a DC shock and arrange a cardioversion for that patient. My approach is that all patients with atrial fibrillation, I make sure that they are rate controlled in the very first instance, initially with beta blockers as first line, and up titrate that to the maximum dose, and then think about adding in digoxin if their heart rate, ventricular rate still remains elevated. Also, it's important to correct for any precipitants, thyrotoxicosis, infection, electrolytes, any ongoing ischemia. Then I reassess the patients and reassess them once their heart rate is below 100, and it's below 110 in patients who are over the age of 75. We call this lenient heart rate control in elderly patients. I will then, once their heart rate is less than 100, their pulse rate, I will then arrange a transthoracic echocardiogram to have a look to see whether there is evidence of structural heart disease and assess the left atrial size. Dilated left atrium may be a sign of a substrate problem, but remember, a dilated left atrium can remodel and become smaller after a period of sinus rhythm. I would then assess the patient's stroke risk and anticoagulate them and arrange an outpatient cardioversion. Now, all patients who have cardioversions, they should have a period of anticoagulation 3-4 weeks beforehand and 4 weeks afterwards. And then I'll reassess their symptoms again in sinus rhythm. When will I use rhythm control? Well, if the patient is symptomatic in atrial fibrillation and they had a benefit in symptoms after the cardioversion, or the echocardiogram demonstrates that they have LV dysfunction, then for me, this is it's very important to consider a rhythm control strategy in these patients. The ones that tend to benefit the most are those who have an atrial fibrillation duration of less than 1 year. If it's more than 1 year, then again, this allows a problem of substrate to develop. As long as the left atrial size is favorable. And the thing I've mentioned here is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy patients, they do not tolerate atrial fibrillation very well. So it's very important for us to try to be quite aggressive in our rhythm control strategy in patients with hypertrophic cardiomyopathy and other structural heart disease as well. The medications that can be used in patients depends on whether they have structural heart disease or not. If they don't have structural heart disease, then flecainide is often first line. Sotalol can also be used, but you have to be careful with your to monitor the ECG before and after you start these medications, because there are risks of proarrhythmia, and particularly in sotalol there's a risk of QT prolongation. And I may even consider amiodarone in patients who have structural heart disease after counseling them about the toxic side effects. And the patient will be referred and considered for a catheter ablation with aiming for a pulmonary vein isolation. So if the patient has poor rate control, if I'm unable to get their ventricular rate less than 100 beats per minute, despite using medications, and when I talk about medications, I mean the escalating their dose. So starting with a lower dose, increasing gradually until you achieve rate control, or until the patient says, I can't tolerate it anymore. Then in that situation, a symptomatic patient with poor rate control, they would benefit from a pacemaker and an AV node ablation. We tend to use this in patients who are older patients rather than younger patients, because having a permanent pacemaker carries significant risks over a patient's lifetime. So in younger patients, we try to avoid using this approach, although it's a very successful approach. In my practice, I do use TOE guided cardioversion, but I do not use it as a first-line treatment. I tend to use it in patients who have unsuccessful rate control and they are unsuitable for a catheter ablation. Okay, so what do you do if the cardioversion, DC cardioversion, is unsuccessful? And I've already mentioned, and I would repeat it with amiodarone on board, an amiodarone facilitated DC cardioversion. And if that still is unsuccessful, then I would rate control the patients. And what I mean by unsuccessful is that I'm unable to terminate atrial fibrillation with a DC shock, despite being on amiodarone. These patients tend to have very advanced disease of atrial fibrillation, advanced stage. And which patient, and just a few notes about catheter ablation in the COVID era. I would say that if the patient has poor rate control, has evidence of heart failure with or without recurrent hospitalizations, then I would consider an ablation procedure in this patient, catheter ablation, on an urgent basis. Which one? Cryoballoon versus radiofrequency. Generally speaking, a cryoballoon pulmonary vein isolation is a quicker procedure. So that's probably what we tend to use if it's just atrial fibrillation. Whereas if the patient has atrial flutter, then we would use a 3D mapping system. Rather than using general anesthesia for the procedures, we tend to use local anesthesia, and sedation to minimize the risk of aerosolization. I would try to avoid liberal use of TOE because, again, the risk of aerosolization during the COVID era, but definitely reserve it for the patients who have a high CHA2DS2-VASc score. And I would consider using CT to assess the left atrial thrombus as an alternative to TOE in the COVID era. Again, you need to speak to your local departments to see whether they can facilitate that. Okay, so lastly, I'm going to just touch on treating and optimizing concomitant conditions. Now, this is an example of a patient who has sleep apnea, and they also have a permanent pacemaker in place. And on the top right-hand side, you can see that there is a chart here. From left to right is time, and each spike is a day. And you can see on the x-axis, you have the number of hours in the day. So it goes from 0 hours to 24 hours. Each spike indicates an episode of atrial fibrillation. And as you can see, this patient is having a relatively high burden of atrial fibrillation. This is before they were started on CPAP. And what happened after CPAP, you can see that it almost eliminated atrial fibrillation. So treating and optimizing concomitant conditions is very effective to reduce atrial fibrillation burden, and is highly recommended to think about sleep apnea in patients who have AF. But there's accumulated evidence to show it's not just CPAP, it's not just sleep apnea. Treating obesity, reducing weight, has also been shown to reduce atrial fibrillation burden, and it has also been shown recently in a study to reverse atrial fibrillation from a persistent type to a paroxysmal type. Similarly, there's recent evidence to show that alcohol abstinence can also reduce atrial fibrillation burden. And anecdotally, you will notice a lot of patients find that alcohol triggers the atrial fibrillation. I've already mentioned about heart failure with reduced ejection fraction, and treating the heart failure by optimizing the heart failure therapies is very reasonable and will also help to control atrial fibrillation. If you can decongest the patient, place them on ACE inhibitors, spironolactone, etc., beta blockers, etc., Entresto, etc. So managing the heart failure can also help improve outcomes in atrial fibrillation, and then hypertension also. Few considerations during COVID is that, as I mentioned, accumulating evidence shows better outcomes with treating these conditions. And because of the COVID pandemic, you may find that elective work is reduced. So there may be delays in patients undergoing catheter ablation. So we should take advantage of this time to allow us to look for these other conditions and manage them to help the outcomes in patients with atrial fibrillation. So I'm just going to go through this poll one last time. So I'm not going to read that again, but if Abdulazim, would you be able to start the poll? So the same case as before, 93-year-old lady, hypertension. Would you be able to start the poll? And the question is, what would you do in this patient? Okay, so do we have the results of the poll? Okay, so now we can see that nearly 70% of the audience have opted for rate control with beta blockers and digoxin, aiming for a heart rate of less than 110, and less have opted for amiodarone. So that's really interesting, and I think that's very reassuring to hear that. And I just want to just talk about the different options and why, you know, what I would think about each of those options. So firstly, I agree. I would initially start this patient with maximally tolerated beta blockers, up titrate as necessary, even consider digoxin, and aiming for a heart rate of less than 110 because this lady is over the age of 75. So that's a very reasonable initial strategy that I agree with. A permanent pacemaker and AV node ablation, well, this may be required if that doesn't work. So if the beta blockers and digoxin is unable to satisfactorily control her heart rate, then I think this is a very reasonable strategy, permanent pacemaker. She's got good LV function, so you put in a standard single chamber pacemaker. A TOE guided DC cardioversion as an inpatient. Well, again, this is something that you may consider if the patient has, if you're unable to control the heart rate, then you may need to consider that, and placing the patient on amiodarone may be required to do that, to facilitate that. So it's not something that I would not use ever. It's something that may be considered. Similarly, it may be reasonable to do an outpatient cardioversion. So if the patient is the heart rate is being controlled, they're on beta blockers, their heart rate's controlled, but they still remain symptomatic, then in that situation, it may be very reasonable to offer the patient a cardioversion as an outpatient, because we think this may be triggered by the infection. So it may be that the cardioversion, we can reassess her symptoms to see whether she improves following an outpatient cardioversion. So that might be an option as well. I've mentioned antiarrhythmic drugs. I wouldn't use amiodarone or antiarrhythmic drugs without knowing whether there is a left atrial thrombus. So some people may not recognize that if you do an electric cardioversion or whether you use chemical cardioversion, the risk of a stroke is the same. So it's not, you're not by using amiodarone doesn't mean that you're safe to use that without anticoagulation on board. And in a patient where you don't know how long they've had atrial fibrillation for, and you don't know whether they've had previous paroxysms of atrial fibrillation, as I mentioned in the natural history, they may have asymptomatic paroxysms of atrial fibrillation. I wouldn't necessarily use amiodarone without anticoagulation on board. Catheter ablation, again, this patient, okay, is 93, so perhaps it may be very challenging, and I haven't done an ablation on a 93-year-old, I'll be honest with you, but you know, it's a reasonable option, something to discuss, but really we tend to do it because of the risks associated with catheter ablation, and frailty as well increases the risks. So in her case, the relative risks of a catheter ablation will be probably too high. So I'm just going to spend the last 5 minutes on a few cases, and then we'll open up for discussion. And I'm going to use the same ECG here. So all the next few cases all have the same ECG. And I think we all agree this is a very common ECG that we see in hospitals and emergency departments on the wards. Atrial fibrillation with rapid ventricular rate. So the first case is a patient who's 55, known paroxysmal AF, has a structurally normal heart, has obesity, is on bisoprolol 2.5 milligrams once daily, and attends the A&E with palpitations and dizziness that have been present for an hour. The patient has taken an extra bisoprolol on advice from the cardiologist, but it's had no effect. And as you can see, the blood pressure is okay, SATs are okay. So how would you manage this patient? And again, I'm going to focus on the three main aspects: anticoagulation, rate versus rhythm, treating concomitant disorders. So anticoagulation. So I would anticoagulate this patient with a DOAC. And you may say to me, but why are you doing that? Their CHADS-VAS score is 0. So, well, this patient, I would need to anticoagulate them because I would be considering a rhythm control strategy in this patient. So regardless of their CHADS-VAS score, all patients who you cardiovert need to be on anticoagulation for up to 4 weeks minimum after a cardioversion to minimize the risk of a stroke. So that would be the first thing. So as I mentioned, number 2, rate versus rhythm. This patient is symptomatic, is known to have paroxysmal atrial fibrillation, so would benefit from a rhythm control strategy, has structurally normal heart, so I may even consider giving IV flecainide in the department. And I may even discharge the patient on oral flecainide, either as a regular dose or as a pill in the pocket strategy. Remember, if you put a patient on flecainide, you must use a beta blocker at the same time. And this is general principle because there's a risk that they can get organized atrial flutter, which can conduct at 1:1, which would be around 300 beats per minute, very dangerous and life-threatening. So never give flecainide or amiodarone, well, never give flecainide without some beta blocker on board. I would then review the patient in the outpatient department and consider catheter ablation. Why? Because they've had a heart failure, they've had a hospitalization, and I would discuss with them about their symptoms. And if they have a high symptom burden, then we may opt for, they may want to consider catheter ablation. In the meantime, I would also counsel the patient about weight loss, and I would screen the patient for sleep apnea. Okay, that's the next case is a 67-year-old lady. She's known to have hypertension. She's had an echo which shows good LV systolic function and mild left ventricular hypertrophy. She attends her A&E department with fever, with cough and breathlessness. Blood pressure is okay, SATs are a little bit on the lower side, and a chest x-ray is consistent with COVID infection. She's lymphopenic, she's got a raised D-dimer, raised inflammatory markers. So this is a case of a patient who has a new diagnosis of AF, likely to be secondary to infection. So what do I do? So let's start off with anticoagulation. So I would during the acute illness, I would anticoagulate her with low molecular weight heparin. And this can then be switched over to a DOAC prior to discharge. Would I go for rate or rhythm control in this instance? Well, actually, I would again start with the rate control strategy. And because she's relatively stable, and I would start her on oral bisoprolol. I may consider giving her some IV metoprolol in the A&E department, particularly if the ventricular rate is very, very high and her blood pressure is good. I would then reassess her symptoms once her heart rate is less than 100. And I would arrange for her to have an outpatient DC cardioversion and then review her in clinic to see how she fared after that cardioversion. Does she have any symptoms? Does she notice any benefit from being in sinus rhythm compared to atrial fibrillation? Was it successful? Was there any recurrence of atrial fibrillation? Thirdly, treating concomitant disorders. Well, we check for COVID, do a swab, treat any concomitant infections, and try to control her blood pressure as good as possible. Remember, bisoprolol has blood hypertensive effect. So you may find that some patients may not tolerate high doses of bisoprolol, and they may be on other antihypertensive agents. So you may consider stopping those antihypertensive agents to allow more of the beta blocker. Okay, third case, 72-year-old lady, known hypertension on amlodipine, known to have ischemic heart disease and has had previous PCI for angina. She's admitted with decompensated heart failure, but denies any chest pain. Her echo shows severely reduced ejection fraction. She's had 3 negative COVID swabs, and she's already been started on bisoprolol and ACE inhibitors, and she's also received diuretics. So what would you do? Again, 3 principles: anticoagulation, rate versus rhythm, treating concomitant disorders. This is a case of a new diagnosis of AF with a heart failure hospitalization and reduced ejection fraction. Okay, so firstly, I would anticoagulate this patient with a DOAC. Number 2, would you go for rhythm or rate? Well, actually, there's a lot of evidence to suggest she may benefit from a rhythm control strategy. So I would start off with oral bisoprolol and up titrate to the maximum tolerated dose, aiming for a heart rate of less than 100. I would then do an outpatient cardioversion, and I would refer her to EP for consideration of a catheter ablation, pulmonary vein isolation. Thirdly, in terms of concomitant disorders, I would optimize a heart failure treatment. I may have to stop amlodipine, and amlodipine is a good antihypertensive drug, but this patient, remember, has atrial fibrillation and has reduced ejection fraction, so they may benefit more from other agents like ACE inhibitors, spironolactone, Entresto. So I would stop the amlodipine to facilitate those other medications. There is a risk of stopping the amlodipine that may exacerbate angina, but again, you're giving beta blockers, so perhaps you're counteracting that effect. So, and then this is the last case. A 92-year-old lady who's known to have hypertension. She's been admitted with decompensated heart failure. An echo shows good LV systolic function. COVID swabs are negative ×3, and she's been started on bisoprolol, and she's been up titrated to 10 milligrams once daily, and now her heart rate is 105 beats per minute, and she's asymptomatic. So this is a case of a new diagnosis of atrial fibrillation with a patient who's got preserved ejection fraction, who's asymptomatic. So 3 aspects: anticoagulation, rate versus rhythm, treating concomitant disorders. So firstly, I would anticoagulate this patient, but I'd be very cautious with the choice of DOAC and the dosing in such elderly patients. Secondly, I would rate versus rhythm. I would stick with a rate control strategy, and aiming for a resting heart rate of less than 110 in the elderly. I would arrange an outpatient Holter monitor to check the rate control over a 24-hour period. And if the rate control is poor, then I may consider adding in digoxin. But you have to remember, digoxin, there are risks with digoxin, and it's not a drug that you would put a patient on and leave them without any follow-up. You must monitor the renal function in patients with digoxin, because there's a risk of digoxin toxicity and digoxin accumulating in renal failure. So you have a patient who has a normal renal function. As time goes, their renal function may deteriorate, and therefore they have more active, the digoxin has more of an active effect and accumulates, and they can have toxicity. You must also look at the potassium as well, make sure they don't have hypokalemia. So I may even consider for this patient, if their heart rate over a 24-hour period is not very well controlled, and if they're symptomatic, then I would consider them for a pacemaker and an AV node ablation. And thirdly, again, optimize other conditions, so optimize blood pressure. So in conclusion, I've talked today about the management principles underlying atrial fibrillation. I've repeated them many times so that it becomes easy, hopefully, for you. Stroke prevention, rate versus rhythm strategy, and concomitant conditions. I think I've shown that you have to have an individualized, patient-centered approach for each patient who has atrial fibrillation. And thirdly, I've also described some of the particular considerations during the COVID pandemic. So thank you very much.
Thank you very much, Dr. Adlan. That is really very comprehensive talk. And of course, there's a lot of learning message from your talk. And at this stage, I would like to extend our welcome to Dr. Abdullah Taib, consultant cardiology from Saudi Arabia, and to Dr. Mahir Hamad, consultant physician in James Cook Hospital, and to our colleague, Dr. Nada Al Taib and Dr. Hind Al Zain. Dr. Randa Al Taib, she is endocrine and diabetes trainee, and Dr. Hind Al Zain, she is cardiology trainee. I think that a lot of learning point from your talk, Dr. Adlan. And to me, to be honest, one of the most important learning point, I think, your summary to CABANA and Castle trial. I mean, it's really, really a lot of information we learned today. I would like to invite now Dr. Abdullah Taib. If you had any comment, please go ahead. Would you please, Dr. Abdullah, just unmute your microphone?
Thank you, Dr. Abdulazim. Thank you very much, Dr. Ahmed, for this very detailed presentation to a very common cardiac and medical condition. And in fact, actually, we learned a lot from your lecture today. It was really very perfect and very good and well organized. My question to you, in fact, actually, I have my colleague, Dr. Safa here, and basically, she always tries to push patients towards ablation or pulmonary vein isolation. And today, actually, she basically have the answer from you. My questions, I mean, what are the successful rate for ablation and pulmonary vein isolation, and what is the recurrence rate? And is that going to put you off about decision of ablation for these patients, which you said with heart failure and atrial fibrillation?
Okay, thank you very much, Dr. Abdullah. Thank you for your comments, and I think that's a really good question. So the answer to that question is it depends on whether the patient has paroxysmal atrial fibrillation or whether they have persistent atrial fibrillation. The outcomes in patients with paroxysmal atrial fibrillation are a lot better. So we quote them around 70% chance of success without the need for a second ablation. About a third of patients need to go on to have a second or even third ablation in order to achieve success. But if you do second or third, your success rates go up to over 95%. So if a patient who has paroxysmal atrial fibrillation, the chance of success is around the 70% mark. If the patient has persistent AF, well, that's a different story. And I think I mentioned about the progression and the difference between a trigger as the cause of the atrial fibrillation versus a substrate. And what we find in those patients, we actually quote them around 50% chance of success. But that means 50% in the chances of eliminating atrial fibrillation. But what we also know is that even if we don't eliminate atrial fibrillation, we can reduce the burden of atrial fibrillation, and it gives them the best chance of doing that. So we may not be able to eliminate atrial fibrillation, but we're able to reduce the burden and change it from a persistent type to a paroxysmal type, which for patients is a very important outcome.
Thank you very much, Dr. Ahmed. Just last question regarding the DUAC. I mean, most of our colleagues, they ask such kind of presentation about your choices about which kind of DUAC you are going to use for the different patients.
Okay, thank you. That's a very good question. And it's a very big topic, and there are some publications about this. So Gregory Lipp, Professor Lipp, he's published on this topic. There's some guidelines from the European Society of Cardiology, which very nicely show how you can individualize and use the anticoagulation in various populations. The general approach is actually there is no significant difference in all of the anticoagulants. They're as effective as each other. There are some situations where I would favor one over another. So for example, if a patient has had a history of bleeding, a very high bleeding risk, they may have had an intracranial hemorrhage in the past, I tend to use dabigatran 110 milligrams BD because that has a lower risk of bleeding. In patients who have renal impairment, the NICE guidelines actually recommend favoring apixaban. I have a discussion with patients and ask them, would you prefer to have a once a day drug or a twice a day drug? And I've had some patients either way. Some patients, their lifestyle is such that they prefer to have once a day, and in which case edoxaban or rivaroxaban would be very reasonable, or twice a day, then dabigatran or apixaban.
Okay.
Can I ask a question, please?
Of course, Dr. Maher, go ahead.
Right. Thank you, Ahmed, first. And I think this lecture is a breath of fresh air, really. I heard a lot of talks about AF, but I think this is the best file so far, really, I enjoyed it. Although I missed the first bit of it. I like the case presentation at the end. And I got two questions, really. One of them is, after cardioversion, when do you stop the DOAC? Number one. Let us answer the first one, and then we'll ask the other one.
So that's a very good question. And it comes down to their CHADS-VAS score. So if their CHADS-VAS score is elevated, so more than 1 in a male, more than 2 in a female, then I wouldn't stop it. If the CHADS-VAS score is 0, then I would stop it after 4 weeks.
After 4 weeks, okay, fine. Obviously, I'm taking this from a general medical perspective. I'm not going to get the details about ablation and things. And even if I ask, I wouldn't retain that. So the other question, I'll give you a case history, or case scenario, which one of the cases which I dealt with, and I will see your take on that. Is that okay, if you don't mind? Yeah. Right. A gentleman who is, I think, 65, diabetic, comorbidity, diabetes, I think, and hypertension. Maybe mild ischemic heart disease on amlodipine, I think, not amlodipine, sorry, ACE inhibitors, and obviously the insulin and metformin. So presented with breathlessness, and when they did the ECG, it was they found AF, cardioverted, started on I think apixaban. I think this was the start, and after I think 3 months, they repeated the ECG. There's no recurrence of the AF, and they stopped the apixaban and they started him on I think on aspirin. After few months, he developed a stroke, which he recovered from that. Obviously, it was a sensory, most probably the lacunar infarct, and the CT scan showed only lacunar infarct, nothing else. So what do you do with it? Do you carry on with the aspirin? Or will you reinstate the DOAC? Okay. Or you can just say or you add what they call, you add one of the clopidogrel.
Okay.
What do you think in this case?
Yeah, that's a very good question. And the use of aspirin. Now, traditionally speaking, we were taught that if you have a patient who has atrial fibrillation, you can either put them on warfarin, or if they have a high bleeding risk, you can put them on aspirin. And subsequent studies have demonstrated that actually aspirin does not prevent strokes in atrial fibrillation. I think that's something that we've learned over the years, and something that's filtering through throughout the medical community, that aspirin can no longer be seen as a preventative medication to prevent stroke in patients with atrial fibrillation. So in fact, the patient should have remained on apixaban and that may have prevented them from having a stroke. Prevention of stroke is not 100%, even on a DOAC, but in terms of what we can do to help, that's the best treatment. The fact they've had a stroke has increased their CHADS-VAS score from 3 to 5. So having a stroke carries 2 points. So this patient had a CHADS-VAS score of 3 because they're over the age of 65, is 1, hypertensive, 2, diabetic, 3. So I think it's a very important message and a very good question is that aspirin, clopidogrel, antiplatelets do not prevent stroke. The reason for it, there's many theories, but the one theory is that strokes in atrial fibrillation are due to predominantly left atrial thrombus, and then it's an embolic stroke. So in fact, aspirin does not seem to have an effect on the embolic strokes, and whereas oral anticoagulation does.
And this is even if the patient had no recurrence of the most probably he could have but there is no demonstrated. They couldn't demonstrate that the patient had recurrence of AF. Still, we could carry on. Yeah,
that's a very good point as well. So the second important point is this patient had a cardioversion, is now in sinus rhythm. When you check for sinus rhythm, you've done an ECG, which is 10 seconds of a lifetime of the patient.
Yes.
So when that patient walks out of the door, you can't guarantee that they have another paroxysm of atrial fibrillation.
Right. Yeah.
There's also a risk that you just don't know. So, we've had patients actually, interestingly, who've had loop recorders, and they've had a loop recorder, they've had a catheter ablation, and we've not seen any AF for 2 years, okay, of a continuous recording. And they ask us, I had a patient ask me, can I stop my anticoagulation? And really, I have to say to them, my advice is no, because I can't guarantee that you're not going to have a paroxysm of AF and then develop a big stroke.
Okay. Oh, thank you, Ahmed. Thanks. Really, thank you.
You're welcome. You're welcome.
Yeah.
Good. I think that is really good comment, Dr. Ahmed. Now, Dr. Mohammed Al-Badri, would you like to add anything?
Thank you. Just I would like to ask Ahmed. Ahmed, thank you very much for this interesting talk. My question is about the use of digoxin in atrial fibrillation. And as you have said, that's very important to monitor the renal function, to monitor the electrolytes. What about the digoxin level? I mean, one of the things which you use to put us off using digoxin in Sudan, we have no digoxin levels. And I'm very worried about putting patients on digoxin for a long time and then they miss their follow-up. So in cases with atrial fibrillation, if there's no heart failure, do you think that still should be a part and parcel of management as an additive for the treatment of atrial fibrillation?
Thank you. That's a very good question. And I think you have an added problem in Sudan of follow-up and not being able to adequately follow up patients. That makes it very difficult to decide what to do. So I think I don't know is the honest answer, is that I think it's a judgment call whether you think if the patient has completely normal renal function, if without digoxin levels, you may be able to get away as long as they can, without a digoxin level, if the patient will agree to having some periodic blood tests of renal function, and that you can assess and make sure that the renal function is not declining. We know the renal function declines with age, but you want to see what the progression of it is. Also, it may be that as time goes, the need for digoxin may no longer be there. So you may want to do a monitor off digoxin to see what the heart rate control is like off digoxin.
Okay. Thank you. I think we got a question on Zoom from one of the intervention cardiologists. Basically, he just mentioning that the geriatrician usually they prefer to give amiodarone in elderly patient. Just they thought that to minimize the hospital admission, given long half-life of the amiodarone. And what's your approach and what's your advocate, Dr. Ahmed?
Okay, so amiodarone in elderly cohort of patients. So amiodarone is a double-edged sword. It is very effective at maintaining sinus rhythm, but it carries risks. And we've seen in lots of studies, patients with atrial fibrillation do badly in the long term So actually, when you prescribe amiodarone, you're potentially prescribing a drug that has an increased mortality risk in patients. That's in addition to morbidity risk with side effects, toxic side effects with long-term use of amiodarone, pulmonary fibrosis, thyroid dysfunction, skin photosensitivity, skin reactions, liver derangement. There's a whole host of these things. So I think if you are going to use amiodarone, you have to discuss it with your patient, make sure that they're happy to have that risk. But it's not something that I would recommend as a routine in patients, particularly if they don't have any they don't have any symptoms of associated with AF, so they don't have very much to gain. So for me, amiodarone, I would look at what am I trying to achieve, what can I gain for the patient, as well as looking at the risks. And if they don't have much to gain, then I would avoid using that medication.
Can I add something here, please?
Yes.
Yes. When I started my training here in UK, it was in late 80s and early 90s. Amiodarone was the use of amiodarone at the peak, and we used to put the central lines at that time. We enjoyed that. Put the central lines, give the loading dose of amiodarone, and it ran out of fashion now. And I think, Ahmed, it would be, I know you did a very excellent lecture about this, about AF, but if time permits really in the future, would you be able to do a lecture about, this will be a benefit not for only junior doctor, maybe only for senior doctor like me as well, is about antiarrhythmic drugs and the classification, which we had the old one and obviously the new one, and there are a lot of drugs run out of fashion. We used to use amiodarone, flecainide a lot, and flecainide a lot, and there's new guidelines now. When you start flecainide, most of you start beta blockers and new trends. So I don't know in the future if your time really, you have time, most of you will benefit from a lecture like that about the antiarrhythmic drugs.
Inshallah.
Simplified. Right.
Hopefully.
Yeah.
Okay, good. Just one question again, Dr. Ahmed. So the question regard failed patient, atrial fibrillation in heart failure post STEMI for those with severe LV and failed response to antiarrhythmic drug in light of CASTLE trial. What's your approach to that?
Yeah, so I think, if you've got a patient with heart failure, they've had a ST elevation MI. So you're assuming that this patient has had the AF precipitated by the MI. That's one of the assumptions. And that the severe LV function is something that's acutely happened because of the myocardial infarction. And in that situation, if the patient's hemodynamics are affected by the atrial fibrillation, then it's very reasonable to cardiovert that patient with amiodarone. And I've seen that approach being used quite successfully. So if the patient is having acute hemodynamic compromise with an acute precipitant, such as an acute MI, then it would be reasonable to use that. In terms of, are we talking about antiarrhythmic drugs, or are we talking about ablation?
I think the question regards if for patient who failed to respond to the antiarrhythmic.
Oh, okay. Yeah. So in terms of, I wouldn't necessarily take the patient for an AF ablation in the acute setting following the myocardial infarction, but I would do a DC cardioversion, perhaps put them on amiodarone and then do a DC cardioversion. I think, is that the question they're asking, or are they asking in the later stages? After
I think the question, they just like providing the result of the CASTLE trial. What's your approach basically in this kind of situation?
I would in the acute setting, I would use amiodarone, DC cardioversion, bring them back to the clinic and discuss a PBI in that patient. But if they've not had any AF and it was just acutely precipitated by the STEMI, then they may not need to have that.
Thank you very much, Dr. Ahmed. I think I would like to extend our welcome to
one question,
Dr. Sofal Tayyib. And yeah, back to you, Dr. Muhammad Badri.
Can I have a quick question, please?
Yeah, just go ahead. Feel free, Dr.
Okay. I'm asking about, COVID patients. Is there any data to tell us about what type of arrhythmias they use? It's just like an infection, as atrial fibrillation could get worse, or their new onset of atrial fibrillation. The patient whom we saw, actually, most of them that came with an MI, and they have got a complete heart block rather than having any other type of arrhythmias. And I don't know what is your experience or what is in the literature about the type of arrhythmias which you are facing in these patients. Okay. The question to ask is, if a patient got an atrial fibrillation and he's quite unwell, and of course we cannot give an amiodarone because his liver function, everything is quietly impaired. The cardioversion in this setup in patients which are in ITU, for example, or ventilated, and is that a bit of a risk doing a cardioversion? And is a cardioversion is reasonable to control the blood pressure? We don't know whether the hypotension is due to other concomitant cardiomyopathy or whatever it is, or due to the fast uncontrolled ventricular rate.
Thank you. Thank you for that. I'll answer the second question first. So the patient in ITU who has hemodynamic compromise, has atrial fibrillation, then for me, the focus of treatment is on what has triggered the atrial fibrillation. What's underlying? Is it the sepsis, infection, dehydration, the AKI? You treat all of these other factors first. If it's causing hemodynamic compromise, then yes, you can advise them to use amiodarone, for example, to try to restore sinus rhythm. The problem is if you do a DC cardioversion, the problem is if you still have the trigger there, then there's a risk that that patient can just, the AF can recur. So you have a situation, you cardiovert, the AF comes back, cardiovert, the AF comes back. So amiodarone would be reasonable in the ITU setting, and we do advise this to our colleagues if they find that AF is causing hemodynamic compromise. The first question you asked was about arrhythmias in COVID. So we've actually published in the British Cardiovascular Society editorials, we've an editorial about this. So if you go to the www.bcs.com website, you'll find the editorial there on arrhythmias. And in very, very briefly, very short, arrhythmias, the evidence is very limited. Observational data, there is a handful of observational trials. We know that arrhythmias occur in around up to 3% of patients with COVID, and this is only data of hospitalized patients hospitalized with COVID. About 3% have arrhythmias. The study didn't say which type of arrhythmia. There was one other study from China where they looked at patients with AF, and they found that of 100 patients, around 4 of them had AF. It's very, very limited data. There are ongoing studies. There's a study at the moment which is recruiting, which is hoping to characterize the type of arrhythmias that patients have in COVID, but we're still waiting for that result. All the other data is just case reports.
Thank you, Ahmed. Dr. Safa Al-Tayyib, I believe you joining us now from your clinic. Thank you very much for taking the time during this very difficult time for everyone. Would you please just unmute your mic and feel free to ask your question or to add any comment to Dr. Ahmed.
Assalamu alaikum, everybody. I can see lots of very familiar names and familiar lovely faces. Thank you very much for having me as a panelist, although it was a surprise for me. I usually like to keep the very back quiet seat and watch and throw questions. Thank you, Dr. Adlan. That was a very stimulating talk, and I think it was a very comprehensive overview of a subject that for imaging specialists we tend to kind of avoid getting deep into. Now, allow me to ask you a few questions. So you do expect that this talk would generate lots of questions. Going back to your Castle patients. Now, I know it was done in the group of patients with heart failure that we all like to investigate HFrEF, but unfortunately the group of patients with heart failure that we tend to avoid, like HFrEF or HFmrEF, we don't know as yet, if I understood from your talk. These kind of patients with symptomatic heart failure and ejection fraction above 40 or above 50, do we know what does ablation do to them? I know you are raising the flag for ablation. You are more of a kind of an ablation person, or pro-ablation efficacy. This is my first question for heart failure patients. Do we know about the data in this group of patients with heart failure? The second question is, even patients who have heart failure with reduced ejection fractions and not good meat for ablation, there are patients whose left atrium have endured lots of remodeling over the time. It's usually dilated with high volumes and high mass. So what are your selection criteria for patients with HFrEF whom you would go for cardioversion amid lots of improvement in heart failure with reduced ejection fraction medications, you name it, ARNI, beta blockers, SGL2 receptor antagonists, and what have you? So if you could answer that part, and then I will give you my second set of questions.
Okay, thank you very much, Dr. Safar. So in terms of patients with HFrEF, that's the CASTLE-AF, the median ejection fraction was around 32% in that group. We don't have a lot of data on heart failure with mid-range ejection fraction, and that distinction I think was relatively recent from the recent ESC guidelines. So I think it's ongoing really, and it's a grey area in terms of the patients with moderate LV systolic dysfunction or mild dysfunction. So it's not clear. We don't have clear data on that, just anecdotal. In terms of assessing left atrial size prior to cardioversion, we tend to use echocardiogram. We look at the left atrial diameter in the plaques view. And yes, this is not a very accurate way of assessing. We can look at left atrial volumes as well, 3D volumes, and have them corrected to body surface area. But for us, it's difficult to know what's going on with the patient. If you see them for the first time with AF and heart failure, you don't know if it's the AF has exacerbated the heart failure, whether AF has caused the heart failure, or whether they have an underlying cardiomyopathy that an AF is a sign of that. So often we have to do interventions and do things to try and tease this out. And with time, we can retrospectively look back and see. So by having an approach of cardioverting the patient and giving them a period of time in sinus rhythm and repeating the echo, we can then see whether there has been a change. And we can look at the left atrium size as well. And sometimes we see that the left atrium size does remodel in a positive manner. So it's very severely dilated. And then once you have a period of sinus rhythm and repeat it, the left atrial size can normalize in some patients. So I'm not sure, I hope that answers your question.
In a way, because you're getting into my next question anyway, how do you feel about a patient who has ejection fraction of about 30% and a left atrium which is quite bulky and dilated and the volume is very high? What about the chances, his chances of getting a successful sort of sinus rhythm and maintaining his sinus rhythm?
Yeah.
What are the predictors of telling you which is which? What do you do? Yeah,
so that's a very good question. And the patient, I would counsel them and say, look, the heart scan is indicating that your chances of success are relatively low, lower. But that doesn't necessarily mean we give up, we don't try, because there are a group of patients who they do improve with being in sinus rhythm. So that left atrium size is very dilated. As I mentioned, it can remodel in a positive way and become and normalize. So we have many patients who have severely reduced ejection fraction, very dilated left atrium. We get them in sinus rhythm, but we counsel them and say it may be difficult, it may not be possible. And to give them the best chance of this, we can offer them a catheter ablation to at least isolate the pulmonary veins to minimize that trigger. When we do our catheter ablation, we get some important data from patients. We can map the left atrium and look at the substrate, look at the voltage. And if we see that the left atrium is severely scarred, then we can actually counsel the patient and say, your prognosis from atrial fibrillation is poor. It's unlikely we're going to achieve rhythm control and maintain sinus rhythm in your case, but we would still offer them treatments to try to help. because they have more to benefit.
Right, excellent. Allow me to give you just one more question, Prof. Just one more. To correct me if I am wrong, I think I did read in a paper that the way you cardiovert acute AF has an impact or an influence on long-term success in maintaining sinus rhythm. Meaning, if you go with an escalation manner versus going into a 1/200 or 360, does that ring a bell? I mean, I might have got it wrong, but
No.
does it make a difference into preventing relapsing into AF?
Yeah, so it doesn't make a difference, because at the end of the day, if the patient has you've terminated the rhythm, then you've terminated the rhythm. Whether it takes you 3 shocks to terminate it or whether you've done it in 1 doesn't really have an impact. It may be that requiring higher energy may tell you something about that patient's atrial fibrillation that it might be more difficult to control. But there was a study last year where they looked at the different doses of whether you use a high dose or whether you use escalating regime, like you were saying, 100, 150, 200. And they found that actually there was no adverse outcomes between the two. One of the concerns people say is that if you use a high energy, then you may expose the patient to higher risk of burns or discomfort from doing the cardioversion. But actually what they found is that if you use the higher energy, you tend to have less shocks required, but you don't have any adverse events higher than if you use the lower dose. So I would advocate a standard high dose.
Okay, thank you very much. It's
Okay.
very useful.
Okay. Thank you, Dr. Safa. And I think now we come to the stage to conclude this session. And